Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another SkinChat webinar. This evening, we're going to be talking about dermatology and the social media era, building awareness of social media's impact on adolescent skin disease and mental health. Our speakers this evening are Dr. Vikash Oza, who is Associate Professor in Dermatology and Pediatrics and Director of Pediatric Dermatology at NYU Grossman School of Medicine. We also have Dr. Evan Reeder, who is board certified dermatologist and psychiatrist in private practice in New York. We'd like to thank our supporter, CeraVe, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you. We'd greatly appreciate it if you would fill it in and send it back to us. Finally, within 1 to 2 days of the webinar, a certificate of attendance and the recording of this webinar will be sent to you. Again, if you want to submit your question, use the question chat pane on the right-hand side of your screen, and I wrote a little note there so you can see where you need to write in your questions. So without further ado, I will pass the floor virtually to Dr. Reeder.
Okay, thank you, Roxanne, and thank you, CeraVe, for sponsoring this webinar. This was something that I was very interested in doing, as if anybody of you know, I'm a psychiatrist and a dermatologist practicing in New York City, so I've always been interested in the interface between dermatology and psychiatry. And I was basically yelling into the void for several years, but now people are starting to get more interested in this interface, and especially even in the beauty sphere, that people are interested in the concept of psychodermatology, which has different meanings to different people. But I think we're going to try to talk about some things that are super high yield for us tonight, for the average medical and cosmetic dermatologic practitioner. Okay, so let's see if my mouse is working here. And you'll have to excuse me. I'm living in chaos right now. I have a infant at home and she may start crying because she's being put to bed as we speak. So here's what we're going to be talking about: dermatologic disease and the adolescent and the interface between that and mental health, why dermatologists have a role in adolescent mental health, what we can do to better assess mental health disorders in an efficient way, understanding that we are practicing in dermatology and that we are not mental health providers, how to recognize body dysmorphic disorder. We're not really going to talk about that in great detail, but we're going to talk about the things you need to be concerned about and why you need to be concerned about that, and body image in general. And then we're going to talk about a little bit about social media, and especially how social media modifies the way that adolescents experience their skin and modifies their experience of themselves. So with that being said, you know, when you think about quality of life and psychology and dermatology, there's many different ways to spin the data, but any different way you spin it, any and all dermatologic conditions are vulnerable to decreases in quality of life and psychological impairment. There is extensive literature looking at conditions like acne, eczema, psoriasis, and some stress responsive diseases like the herpes simplex virus, which tends to come back in the most inopportune times and times when people are stressed out. But we're really going to be talking about the primary dermatologic conditions with secondary psychiatric manifestations. Of course, the field of psychodermatology or psychocutaneous medicine, there are primary psychiatric diseases that have secondary dermatologic manifestations, like when people are really anxious and they're scratching at their skin, or people with acne excoriae when they have basically not able to come up with the words that they need to be describing their emotions, and instead manifest it on their skin. We're not really going to be talking about that. We're going to be talking about these high yield, really common diseases that we see in the adolescent population. And I think it's important to talk about body image and face, because this is basically what our adolescent populations, our children, our patients, and our family members are looking at every day when they go on social media. It's in the palm of their hands. And I think that body image and face image and body dysmorphic disorder as a larger category is really an emerging area of concern for some inflammatory conditions, and we'll show you the literature to back that up. Okay, so without further ado, I'm going to introduce my colleague and good friend, Kashi Oza. Dr. Oza is an associate professor of dermatology and pediatrics at NYU, director of pediatric dermatology NYU. And fun fact, we used to share an office when we both started at NYU. I've since left to go to private practice just in the fall, but we maintain close contact and we're very happy to have him with us tonight. So with that being said, I will turn over the microphone to Kashi.
All right, Evan, thank you very much. And thank you guys for spending part of your evening with us on the session, which is fantastic to have a opportunity to speak about adolescent wellness and mental health in our field of dermatology. So I'm just gonna. Okay, so we're going to start with a question here just to sort of whet the appetite of which of the following conditions are not associated with atopic dermatitis. So I kind of want you to think through just some of these and select the one you think has not been associated with AD. So we'll take a second while you pull your votes. And then we have a second question that we'll go through as well. You guys are off to a great start. Okay, great. So we see here that there can be a pretty broad spectrum of mental health related issues associated with probably our most common chronic inflammatory disease in dermatology. So let's look at a second question. Okay, which of the following may modify the relationship between adolescent acne and depression? So which of the following may increase depression? So if you think through that, being placed on isotretinoin therapy, a concomitant diagnosis of polycystic ovary disease, identification as transgender, acne severity, or childhood obesity. Okay, great. Very good. So we're gonna work through this one here. This gets at both baseline demographic factors in the adolescent period and depression. And so our discussion here tonight kind of comes at a time where we are seeing this conversation start at our national level and at our highest levels. As many of you may have heard from the media, Dr. Vivek Murthy, our Surgeon General, has already put out last year the alarm bells about the rising rates of adolescent mental health issues, specifically depression, that have emerged since the pandemic. And just recently, over the past couple of weeks, identified social media use as something we all, parents and clinicians, should be paying attention to as a potential important influencing factor on a child's sense of wellness. And Dr. Reeder is going to kind of get into that in his section of tonight's program. So I thought we'd just kind of start with the lay of the land in looking at adolescent depression. So these rates vary by years, but what we do see is it being one of the most common childhood diagnoses during the adolescent period. With an overall prevalence rate of up to 17%, and strikingly in adolescent girls, nearly 1 in 4 during their adolescent period may qualify for a diagnosis of major depressive disorder. And what we do see is this upward trend. As you age into your teenage years, one's risk of having major depression increases as well. And this is no sort of demographic is spared, and we've seen striking rises in certain demographics, such as African Americans as well. So every group depression exists within. And then obviously when we look at overall childhood health in the United States, you know, a metric that we always pay attention to is obviously mortality. And suicide has now taken the place of the second leading cause of death in adolescents. So this issue is something that we have to be mindful of as just clinicians in general. We were already seeing rising rates of diagnoses of depression before the pandemic, but obviously the pandemic changed our world and the landscape for mental health. On the graphic on the left, just looking at emergency room utilizations for acute mental health crises, and you can literally date it to the point where the pandemic started. And you know, now globally, 1 in 4 children expressing depressive symptoms. And so one thing that the pandemic has brought towards us is this eye-opening realization that this is a true public health crisis that we are dealing here with in the United States. And it's provided us more opportunity to talk about this in many different forums, including tonight's forum. Okay, so I think as Evan was just alluding to, we are all busy dermatologists. I'm a pediatric dermatologist. I only see children, was initially trained in pediatrics and then in dermatology. So I think part of it is just influencing ourselves is why us? As Evan mentioned, we're not trained mental health providers. So I'd like to just take a second to build an argument of why we should pay attention to some of these issues. So here are 4 of probably some of the most common inflammatory conditions that I see as a pediatric dermatologist. And when we think about these diagnoses, I think part of our job is for screening for comorbidities. You know, in each of these conditions, we, in our review of systems, might ask about a potential comorbid condition, doing our good faith as a general provider. So, for instance, a child that you see with psoriasis, you're going to be asking them about joint pains. You're going to be searching for other atopic comorbidities in an atopic derm patient. You might think of other autoimmune mediated issues like an alopecia areata or menstrual irregularity in a young girl with acne. But truly the one unifying diagnosis that cuts across most inflammatory conditions throughout childhood is depression and depressive symptoms. And there are many ways in which this can be screened for. Oops, sorry, we'll go back for a second. But you can see here that, for instance, in psoriasis and acne, where we see up to close to about 20% meeting a clinical diagnosis of depression and expressing depressive symptoms as probably one of the most common comorbid features that an adolescent with any of these conditions is likely to have. So one could build the argument that it's because these are really the issue that is most associated with their disease. When we think about the reason as to why, obviously that it's inherently highly complex, and there's many intervening factors that are occurring. And there may potentially be a role for an argument of what it means to have systemic inflammation, its influence on the brain and the adolescent brain. But one of the ways we see some of this modified in the diagnoses we're going to discuss today is the role that they can play in causing internalizing behavioral symptoms, withdrawal. And we know that the feelings of social isolation and developing poor social attachments to those around you are discrete and predictable risk factors for depression in the adolescent period. And we see many of our conditions influencing depression that way. We'll just take 2 of our most common things that we see as a dermatologist taking care of adolescents. Clearly, atopic dermatitis, you know, greater than 10% of the population in this age group has atopic dermatitis. And we can see in terms of quality of life impact, influence being very broad and cutting across all sort of spectrums, whether it's just your ability to function in school, whether it's your ability to make meaningful and worthwhile social attachments, which are critical at this period of time. There is a mountain full of data expressing how atopic dermatitis greatly impacts the quality of life of children. And you can see here during adolescence, when you're starting to develop relationships and social attachments, how broad the impacts can be. We know just in terms of adolescent medicine, the experience of bullying is also a risk factor for things like depression and suicidality, and how often children, particularly with a severe disease, may experience bullying during their adolescent period. And seeing rates such as up to 80% of teens avoiding a particular activity because of their diagnosis. So when we're trying to decide on therapies, we're constantly thinking about the quality of life that the disease is having, so we can make the best choice in terms of therapeutic for our patient. Here is just a study that shows us that what would seem kind of common to reach a conclusion is that disease severity plays a very important role. So when we look at the likelihood of having depression, this more severe disease in atopic dermatitis during the adolescent period of time, the more likely of meeting depression, and that we see these issues existing across age groups. Actually, in the study, going down to the age of 4, having internalizing behavioral symptoms of withdrawing and decreasing social attachments related to the disease exist even at an early age. So let's take a look at acne. You know, in terms of acne, we can see patients who suffer from severe acne during their adolescent period, up to 1 in 4 may have thoughts of suicide. When we look at large studies and we look at, you know, the impact factor that having more severe acne has in terms of things like bullying, relationships with friends, we see the statistical association. In terms of suicidal ideation, we can see a nearly 2-fold increase when teenagers self-rate their acne as being on the severe spectrum. And so we have plenty of data to say even the things that you see every day in your office have a very meaningful impact on serious mental health issues in children. This was a study that kind of a longitudinal study looking at children over years. And one interesting point to bring up is the risk for depression and acne in adolescence. You can see how it seems to be greatest very early on since the onset of acne diagnosis. So this might be an important window of time to talk about some of these issues. I see this as a pediatric provider, particularly when we're talking about children who are suffering from more moderate to severe acne at a young age of onset. It makes them further seem disconnected from their peers when they happen to be one of the younger children in their age group dealing with acne vulgaris. Okay, now if we build an argument saying, well, clearly we see that these mental health illness coexists with many of these conditions, and in our routine review of systems, we should be thinking about this. Also, our guidelines can play an important role in forcing us to think about these issues. You know, one of our challenges here is that we don't necessarily have discrete, for instance, American Academy of Dermatology guidelines on pediatric alopecia areata in terms of screening evaluation, but we do have some. So it is codified in terms of an annual assessment for psoriasis. But I think we also have some work to do at the society level of building out recommendations for mental health screening for many of these conditions. All right, and another thing is just the frequency in which we see our patients. So if you thought about patients who may have more moderate disease in any of these categories, how often as their dermatologic provider would you be evaluating a patient? You can see quite frequently. So one could build the argument is that we have a touch point with this vulnerable population, oftentimes multiple times during their middle school and high school years. When we compare that to their primary care provider, their pediatrician, it is recommended for pediatricians to use a validated screening tool, which we'll talk about, to screen for depression for children 12 years and up. But you can see not even 80% of adolescents have a primary care visit once a year. So especially for these patients that we're seeing, we're just frankly seeing them more often and have more ability than potentially other providers to actually ask these important questions and ask to see how they are doing. And then lastly, we exist in an era where we are increasingly utilizing novel therapies for many inflammatory conditions. Our toolbox has drastically increased over the past several years of what we have available to help treat moderate to severe disease. And with that comes patient-reported outcome measures. So our ability to utilize kind of tools that allow the patient themselves to assess how severe their disease is. And we use that as part of shared decision-making to decide what next steps are available. And so there's also interesting data on having active anxiety, active depression, on how the patient actually rates their own disease, and seeing that you're more likely to overestimate potentially the severity of those symptoms when we have this as a modifying sort of factor. So it modifies also the way the patient perceives their own disease. And so why us? I think there's many things that we kind of touched upon. If we think about the most common condition they're also likely to have, it's likely things like depression. We will see probably more and more these being worked into guidelines that we use that govern our practice. We are the providers who potentially may have a number of touch points to discuss these issues. And then if all else fails, we commonly prescribe a medication in which a family is often providing consent that discusses the potential for mental health issues surrounding it. And so any of us who prescribe isotretinoin to the adolescent population, whether we like it or not, are engaging in the conversation about mental health. And so during our busy practice, when we may have 10, 15 minutes, if we're lucky, to talk to families, when do we pump the brakes? When do we stop and think about asking questions in our daily practice? Some might make the argument we should ask it for all adolescents, given the high rates that we already saw. But I think in my clinical practice, a number of things that come up which make me kind of stop and think. So when we're doing an exam and we happen to see self-injury as part of the exam, but that's not brought up by the family. As we just discussed, sometimes we're forced into these conversations by medications that we prescribe. When we're seeing, as Evan alluded to, sort of potential psychiatric comorbid issues as a potential driver to the dermatologic picture that we're seeing. When you have that sixth sense and you're getting a sense in the room that something feels off. And then lastly, we'll talk about body image. When we start to see high focus on things that seem kind of fairly minor, but are persistently being perseverated upon. When we start to think about the idea of the influence of body dysmorphic disorder in a patient. And so, and then also just what's listed in their past medical history. So when we think about things that influence depression in adolescence, so children who are struggling with obesity, we see higher rates. Obviously, LGBTQ adolescents have a much higher rates of suicidality and depression. When there's documented in the note past issues of substance abuse. And as we'll talk about before, the biggest risk factor for suicidality in an adolescent is a past attempt. And that's sort of the risk factor that has the highest influence factor. And so how do we even start to talk to an adolescent about this? So obviously we don't have often the opportunity or space to go through a thorough proper adolescent interview. But I think when we're worried or when we feel like we need to talk about some of these issues, I think the better judgment is to understand that these are often conversations that are best had with the adolescent themselves and with a parent not in the room to really get at what's going on. And so it allows us an opportunity, and it's important to have a script to be able to say to a family member, it's common that I like to talk to my patients by themselves just to get a sense of how they're doing. And you can ask them, about their overall wellness and how they're feeling. But we also have tools that are highly vetted and used in clinical practice that are quite successful at identifying depression in the adolescent period. So I'll just share one that we use in our practice, which is called the PHQ-2 tool, where it simply asks a person in the waiting room or while they're waiting for you while you're finishing your notes, 2 questions. Having little interest or pleasure in doing things, feeling down or depressed or hopeless in the past 2 weeks. And we can see here, scoring 3 or more has a fairly high sensitivity in picking up an adolescent who has depression. Technically, this is often followed by a more detailed survey tool, which is just simply 9 questions. And when you total those up and you fall into this 10 or more, this is really someone who you need to potentially get in touch with a pediatrician, have a conversation about seeking additional care. Both Evan and I had found this article quite informative that was published in JAMA Derm several years ago that made use of the PHQ tool and an algorithm to give you a sense of how you might work that into a busy dermatologic sort of practice. So scoring 3 or more, as we talked about, as being a risk factor for major depression, well, that provides you the opportunity to ask 2 specific questions that are attempt to get at risk for suicidality. Do you ever think about ending your own life? And if yes, do you currently have a plan? If the answer to those are yes, your next option is really talking about a potential need for emergency care. And so these are conversations that might be something that you could look to think about. I think important in the adolescent interview is establishing what are the rules, the privacy rules around your healthcare, and it might differ by state to state. Here in New York, I often start these conversations by creating a normative environment for the teenager, discussing that having severe acne or eczema is pretty common to experience times of feeling sadness or anxiety, to set the stage that, as we just reviewed, these things are quite common. Also set the stage that there are privacy rules that dictate the relationship that we have so we can provide the best optimal care. So, one being that we might need to seek more help if someone's actively planning on hurting themselves. 2, someone's been hurting them or they plan on hurting somebody else. And I usually start the conversation by just having them recap to think about the things that we've already talked about with the parent in the room and having them reflect on how their condition is really impacting them and their own goals. And asking them, have they felt more sad more often than not? And then also finishing off with asking them what would they do if they felt symptoms of depression or suicidality, because there are useful tools now as of this summer, and I often discuss this with adolescents, is if you're ever feeling that sad, we have a national hotline in the United States, 988, which can be called to connect you 24/7 here in the US with support. So that's an easy tool that you could refer patients to. So that's a bit of a whirlwind of how I think through things as a pediatric dermatologist in the adolescents that I see. And now we're going to hear a little bit about Evan to discuss what it's like to experience your skin disease as an adolescent in the social media era.
Great, and I will try to be limited with my time so we can have a couple minutes for questions at the end, because I see it's already about 7:30 now. Okay, so let's see if my mouse is working. Bear with me one second here. Okay, polling question. All right. Oops. Social media is a negative force in the lives of adolescents. Select one of the following: strongly agree, agree, neutral, disagree, or strongly disagree. Give it another 20 seconds or so. While you answer this question, I will say that that algorithm that Kashi showed looks horrible from a distance, like so many steps, but it's actually pretty easy to use, and it's really just an easy way to destigmatize asking questions about suicidality if you are concerned about that. And again, your job is not to be a mental health professional. Your job is just to assess for safety and then get the person into the right treatment provider's hands. Okay. All right. So strongly agree, negative force in the lives of adolescents. You could also make the argument it's a bad influence in the lives of adults as well. So, but agree and neutral, but there are some positive things that come from social media as well, and we'll talk about that too. Okay, see if I can advance here. Oops. Okay, here we are. So adolescents and social media, we'll try to go through this efficiently. So we all know that now smartphone applications are super widespread. Everybody seems to have them, and kids have them younger and younger now. It's really incredible in terms of online support and getting information. Some of those information sources may not be reputable though. And when assessed by the general population, 36% of adolescents said they spend too much time on social media, and 35% said they're using social media almost constantly, which I think is really problematic. And now we have tons of different applications that are available for both photo and video-based content. There are applications that allow you to modify your appearance with photography. There are applications that allow you to modify your appearance with video, which is scarier. But these are all super readily available on smartphones. Some of them are free and they're very widespread, but they're very integral to the way that adolescents communicate. And I think that you're going to see a new generation of adolescents that grew up during the pandemic. They didn't have enough time to socialize with their peers that are going to be relying on these even more. And there may be some stunting that happens in the terms of the social skills. Hopefully they will have reconstituted some of them by the time they grow into adolescence, but we're probably seeing some of the effects of the pandemic happening in our child population, and increasingly more we'll be seeing it in our adolescent population as well. But as we know from a lot of dermatologists who have social media platforms and a lot of skincare influencers, a lot of people get their information on dermatology and skincare from social media. Again, some of it's good, some of it's not so good. Okay. And we also know that social media has a very powerful effect on frequent application users. And this impact on adolescents may be much more profound because of their unstable sense of self-worth. You know, adolescence is a very vulnerable time in life. You're sort of consolidating your identity in the coming years. You feel vulnerable to the opinions of your peers. You often don't have a good sense of self. You don't know where your place in the world is. You may not feel confident in your own skin. It's very rare to find someone at that point in their life where they do feel that sense of confidence. So if people are spending a ton of time on social media, they can make them exceptionally vulnerable. So again, like I said, physical and social comparisons, looking constantly for the approval of peers, and body self-consciousness. All these things really get filtered through the lens of the sort of quintessential form of communication on social media, which is the selfie. So selfies, I'm assuming that everybody in this audience knows what selfies are, but they invite instant positive or negative feedback from peers. And I think that they're really a terrible thing to be put in the hands of, well, an adult for one, but for certain children or adolescents who are so much more vulnerable and have not consolidated in terms of their identity and their place in the world. Okay. However, there are benefits to social media use that you can see if you are able to step back. Connection, support, especially if you live in a place where you may not be coming across a ton of people who are like you. If you're LGBTQ and you don't live in New York City, it may be a more difficult experience than for our youth who do live in New York City, who still have a more difficult experience because of the nature of how they identify. But in closed communities or open communities in social media platforms, it gives an area for safe identity experimentation and the opportunity to build a community that you may not have been able to do in real life. But as we know, there are many negative impacts of social media use, and this has really been explored pretty thoroughly in the psychiatric literature and the psychological literature as well. Increased risks of anxiety, depression, self-injurious behaviors, including suicidal ideation, and then body image concerns and face concerns. They're sometimes tied to diseases of the skin. But I think it's really important to sort of take a step back and think about the recent history of the beauty industry and skincare industry and what it basically has exposed our adolescents to. In my lifetime, we've made a large jump with the introduction of injectable medications and rapid technological transformation. So what used to be in the unique purview of the 1990s art director from Vogue magazine, it's now available to the average consumer and the average adolescent through free apps on their smartphones. So if you're of my age demographic in the 40s and above, you probably recognize the supermodels of the 1990s. And on the right here, we're going to show you an example of a heavy filtration on an app called Facetune. I don't even know if this app exists anymore, but this is what people could actually do with a swipe of their finger, and adolescents and young adults were doing this all the time, at least during the pandemic. I don't know if Facetune is still out there. While this has sort of democratized the beauty industry, making celebrities and millionaires out of regular people with a good rig lamp and a microphone, it does not come without its psychological challenges. And we know that the psychological effects of social media can be pretty profound. But you know, the story of Instagram and apps like that were conceptually great, especially Facebook and Instagram for building communities. But most of the data shows negative impact, although there is some of that positive impact that we have seen and I have talked about in the previous slides. But this is really like the sort of a universal excuse me, story about Instagram. People go online, see people pictures of like their most curated pictures of their lives at the beach on vacation, and then it instantaneously makes people feel badly about themselves. I know this happens with me. Okay, so I want to talk about two psychological concepts, and it'll be clear why I'm talking about them afterwards. The mere repeated exposure effect is a social psychology concept that is widely used in marketing, okay? And basically it says, the more you see or hear of something, the more you like it. This happens when you hear a new song that's not like a total bubblegum song that you like once and after 5 listens, you don't ever want to hear it again. But things that you hear repeatedly, you will like more and more with repeated listens. And we tend to like things that are just more when they're more familiar to us. And we see this for those of us who practice in the cosmetic dermatology setting. We see this when we go to conferences, and then we see sort of dysmorphic people walking around the conferences, but sometimes in those environments, they may feel attractive or normal because the concept of beauty gets shifted and altered. Okay, so on the right, I want you to see there's a picture of my Instagram feed here. This is from probably a year ago. This was, developed using AI based on my preferences and the things that I click on. So there's like some puppies, there's some musicians, there's some football players, okay? But what does it mean and how does it affect your feed? Oh, I'm missing my picture here. The next picture was supposed to be another picture of an Instagram feed showing a bunch of lips, but that has seemed to have been edited out. But we know that this mere repeated exposure effect, when you're exposed to repeated images of things that you didn't necessarily find attractive, but you can continue seeing them over and over and over again, you will find them to be more attractive. So when people are seeing images of large lips, of beautiful skin, of features that may not look normal in a normal everyday setting, they can actually find those things to be more attractive. And this is found to be true across cultures and independent of people's awareness. And it's basically showing that our perception of beauty is not necessarily static. Again, repeated exposure of something increases our preference for something. Now, I want to talk to you about one other concept which is happening to our adolescents as they're using social media and visual adaptation. So visual adaptation is a temporary change in sensitivity or perception when someone is exposed to a new or an intense stimulus, and there's sort of a lingering after image that may result when the stimulus is removed. Sort of like what happens when you see lots of rapid fire imagery on Instagram, okay? So here, oops. So here's a couple images of, we didn't think we were talking about cosmetics today, but you'll see why it's important. Here's a couple images of lips that were before and after. Before on top, after's on the bottom. And if you look closely, you may say, I don't really notice a difference, but that's good. You're sort of not supposed to see a mega difference when people have their lips injected. But on further inspection, we notice the lips retain their anatomic proportions, but gain a subtle increase in volume and the appearance of hydration below, right? Sort of looks normal, looks a little bit more healthy, maybe a little bit more plump, okay? And most of us would appreciate subtlety in this. However, knowing what we know about the mirror exposure effect, the repeated exposure effect, where you like something more after you see it more, and the AI algorithms of Instagram, multiple repeated exposures on a daily basis, is it any wonder that we have seen the evolution of lips and other features of the body to become dysmorphic and even outrageous, starting with normal to going to overfilled to dysmorphic to sort of inhuman on the right here. And while this is a really drastic example, we see this happening with acne as well. We see kids who are wiping away their blemishes. We see kids who are zeroing in on a single blemish, maybe two blemishes, and really warping the way that they see themselves. This was actually given, there was an interesting study that was presented at a cosmetic meeting a couple of years ago. It was never actually published, but it was shown as an oral presentation. So people were shown multiple photos of lips of varying sizes and asked to note their preferences, okay? Then they were exposed to repeated rapid imagery of larger lips, okay? After a few minutes of this exercise, they were then asked to tell the audience about or the researchers about their preferences again. And this time, after just a few minutes of seeing images of larger lips over and over and over again, they favor lips that were 30% larger than their pre-exposure preferences. So this is sort of like a small study that validates what we're seeing clinically, and that is basically social media algorithms, their AI algorithms are skewing our perceptions of ourselves. So we have kids that are coming in and young adults that are coming into our practices with requests for skincare and requests for cosmetic procedures, or obsessed over minor defects in their skin that may have been triggered or made worse by the influence of social media and the way that they have been perseverating about their facial features. Okay. So it's not hard to imagine how feeds like this, with all these lips and all these skincare photos, can both increase our preference for larger lips, increase our own focus and scrutiny of our own features, and begin to feel self-conscious. And now imagine how this feels if you are already living with an inflammatory body. It would naturally follow that you're going to feel more self-conscious. You may feel less socially outward, and you may develop tendencies towards social anxiety, less interaction with your friends, maybe you may not go to school, maybe you won't go to school unless you're wearing a heavy amount of makeup, maybe you won't socialize, maybe you won't go out on dates anymore. I sort of alluded to this before. This has changed the doctor-patient relationship, and not only in the aesthetics sphere, but in spheres where people have a skin issue in a part of their body that is facing the public, like on their face, like on their arms, like on their hands. And this happens all the time with our acne patients, with our eczema patients, and this is getting worsened by the effects of social media. And this is really affecting the doctor-patient relationship, because we're put in this position where we don't really know what to do when we see something that is an aesthetic or a medical concern that may be out of proportion to what we're seeing in our objective assessment of the physical examination. Given the given the time, I'm probably going to skip the Snapchat dysmorphia, but people are modifying their selfies and modifying their face and feeling badly about themselves. Okay. So the relationship between body image, body dysmorphic disorder, and face image and social media is very complex. We don't know exactly why body dysmorphic disorder happens, but there are genetic environmental factors that go into it, and genetic factors seem to compose 37 to 49% of the variance, depending on how you look at and which studies you're reading into. So, and I don't want to belabor the diagnosis of body dysmorphic disorder, but I want you to know that people with body dysmorphic disorder look normal or they look attractive, but they are completely fixated on something on their face and their body that's taking up an inordinate amount of time. Our job as dermatologists is not to diagnose body dysmorphic disorder, although I would argue if you're running a high volume cosmetic practice, that is your job, but to notice it and to notice the things when things don't seem right. If you have an adolescent coming into your practice where the skin looks very good or almost perfect and they're completely obsessed or they're perseverating about something, you should be thinking about a body dysmorphic disorder, especially if they're spending a lot of time. People with body dysmorphic disorder spend more than 1 hour a day basically wasting time perseverating about something with their appearance. Okay. So we know that adolescents with body dysmorphic disorder use Snapchat and Instagram for longer periods of time, and they're more likely to compare their image to that of a celebrity. And we don't know if this is causal or if this is just associative, but this has been published in the data. But many studies show that more time spent on editing photos has been correlated with greater body dissatisfaction, negative body image, and the greater consideration of undergoing cosmetic procedures. And this does happen in adolescence, which sounds crazy to probably some people on this webinar, but adolescents are thinking about things that they probably shouldn't be doing at early ages. And there's data to back up adolescents being dissatisfied with their body image or with body dysmorphic disorder. That here's a couple papers that I won't go into in depth. So at this point, we don't know if social media use is a risk factor or an exacerbating factor for body dysmorphic disorder. And you may be asking yourself, why is this important? Well, I want to show you one study that I don't know if it got a ton of attention in the US media, but this is in the British Journal of Dermatology just last year, major study, and I have this here. I wrote it down. More than 8,000 participants, more than 5,487 consecutive patients with different skin diseases recruited among dermatologic clinics in 17 European countries and 2,808 healthy skin controls. Okay, they assessed body dysmorphic symptoms by something called the Dysmorphic Concern Questionnaire, and all patients were given a dermatologic diagnosis according to the ICD-10 by dermatologists. I think this is the thing that I find to be very compelling and I think probably very surprising. Tons of our patients with inflammatory skin conditions are living with body dysmorphic disorder and we're not even realizing it. Hyperhidrosis, alopecia, and vitiligo had more than an 11-fold increased chance of having BDD symptoms compared with healthy controls. Atopic dermatitis, psoriasis, acne, HS, prurigo, and bullous disorders had more than a 6-fold increased chance of having BDD. Okay, so we are seeing this condition. We're just probably not asking the right questions, and we don't even know that we're seeing it. And body dysmorphic disorder is really important for many reasons, which we won't get into today. But I want you to think about patient outcomes and patient quality of life. High rates of suicide, high rates of depression, and other mental health comorbidities with body dysmorphic disorder. So teens who are really perseverating about something on their skin that is not severe, you really want to be on high alert for this. Suicide is your biggest concern here. Okay, but fear not about social media. We know this is really easy, low-hanging fruit here. Reducing social media use improves appearance and weight esteem in youth with emotional distress. A very brief 4-week intervention using screen time trackers showing that there was, with decreased social media use, improvements in appearance and weight esteem in youth with increased social media use. And there's different ways to define increased social media use, but it's usually 3 hours or more, which is an insane amount of time, but I've done it myself and that can happen very quickly without you being aware of it. So it begs some questions for me. Should we be screening our kids for social media utilization? We do this with body dysmorphic disorder. How much time are you spending like in the mirror or thinking about the whatever part of your face or your body or your hair that you find to be unattractive? And like if that is over 1 hour or more, then we should be probably recommending detoxing from social media. Setting limits for sure. Removing social media entirely will probably have inordinate benefits on our adolescents' mental health if they are social media utilizers or overutilizers, should I say. And there's something called the BDDQ for adults, which is a body dysmorphic disorder questionnaire. and it has been adapted for adolescent populations, which I will just show you. And you can ask this single question, and it has very high sensitivity for catching kids with body dysmorphic disorder. Are you worried about how you look? And I would argue if someone says no to that, then you're done. If they say yes, then I would ask them how much time they're spending about their appearance-related concerns. If they have severe nodulocystic acne, it's very understandable. But this is a question that you use to screen kids who look normal but are fixated or perseverating on something that you can't see or that is very, very minor. Okay, and that's just a picture of that questionnaire, which is free to use. If you're interested in this topic, there's a publication that our group came out with. We had a Delphi consensus looking at these psychodermatologic concepts, and that'll be coming up in an upcoming issue of the Journal of Drugs and Dermatology. There'll probably be another couple other articles to follow that up. But I just want to wrap things up. These are our conclusion statements in that article that I don't want to belabor. But beware of the profound mental health comorbidities in our vulnerable adolescents. Be mindful about the outsized impact of social media on their self-image and the psychological functioning. And consider using these high yield, I think low time requirement screening tools that you can probably memorize. 1 question about body image, 2 questions about depression when you think it's appropriate. And strongly consider limits on social media use or a total detox. With that, we have a couple questions left or a couple of minutes left for questions. I appreciate you guys tuning in, especially after a long weekend and especially at this time of night when you could be doing other things like having dinner. Or maybe you're having dinner. Okay.
So please submit your questions in the question chat on the right-hand side of your screen. And if there's any additional questions that you want to submit after this webinar, you can always send them to info@rbcconsultants.com. We'd like to thank our supporter again, CeraVe, for making this educational event possible. So we have a couple of questions from the audience. After all of that, do we really need to ask adolescents about social media use as dermatologists?
Yeah, I mean, I think adolescents these days are very keyed into, I think we're all sort of keyed into sort of this idea of wellness, and even adolescents are, also, keyed into sort of wellness. So I think if they feel like it is having a negative impact on them, I think it's important to identify that, and it's kind of a conversation starter between a parent and their teenage child, or when you're trying to get a sense of the impact that their social media use is having. Yes, how much time they spend on social media. I mean, they're all like, that's literally the way they exist and the way they engage, with their peers today. But it's really when it veers off into being problematic and when they identify as a potential desire to make a change.
Yeah, I think I would say the same thing. And you kind of have to assess out the situation because kids are going to use social media. I use social media, and there are definitely days when I blow through a couple of hours on there. And usually it's not making me depressed, but I'm also not looking at images of skin and like beautiful vacation spots. I have like other super esoteric interests that you would find to be boring. But if kids are really, if they're struggling with something skin related, and you're sort of picking up on that in the interaction, this may be a down the line tertiary or quaternary question that you may be asking them about.
Can we use the algorithm for adults as well, or is it only validated for adolescents?
Well, the PHQ system, PHQ2, I believe, is also validated for adult patients as well. It's for kids. It's typically 12 and up when we're utilizing that screening tool.
Yeah, I think most of the data come from the adult population, and it's pretty high yield. You'll get a lot of information about with 2 simple questions.
So if we identify BDD symptoms, would this trigger a referral to psychiatry, adolescent medicine, or are there other suggestions that you typically make? Counseling, social media, detox?
I think it's a really good question. I give talks just about BDD because there's people have so many questions about it and it's so scary to them and they don't know what to do. And I think the concept of BDD in the adolescent patient is a relatively novel one at this point. And I don't know if, Kashi, if you heard people speak about it before, and I don't know what you do in your practice, but I think the most important thing is for me, it's suicide. And dermatologists don't like to talk about this, but you should just like you have a speech when you talk about acne and like this is where acne comes from, and or what's a normal mole look like, what's a freckle, and what you just have to totally destigmatize it for yourself. So when you see BDD coming in the door, and you will if you're looking for it, it becomes a speech that becomes rote to you. And for me, when BDD comes into the door, it becomes very interesting to me, right? Because I'm like, okay, I'm going to give this person information that they're either going to be, it can potentially change their life, or they're going to hate me and they're never going to come back. But I know that I'm going to save myself from doing something that I should. I'm not going to do a procedure on someone who doesn't need a procedure and who will not do well with that, or I'll be eventually hooking somebody up with a mental health referral who's going to make use of that. But the question of getting someone into mental health is a very difficult one, and everyone has a different way of doing it. But I think you have to build rapport with someone first over the course of weeks, because if you say, I think you need to go see a psychiatrist, they're gone, their history. But Kashi may have a different way to.
I mean, I think one thing that became new to me from having these discussions, with psychiatrists, is that the diagnosis often starts in adolescence. So you have the opportunity to potentially make the diagnosis early, independently associated with much higher suicide risk. I think again comes down to the question of, do you find it challenging to not think about this issue? Does the patient have insight that they are struggling, whether it's, a perceived blemish? Do you have a hard time not thinking about that? And if the answer is yes, there might be some self-insight already there. And then I think probably the most appropriate referral would be to psychiatry. Granted, you have a psychiatrist that's available and is in their insurance plan. Obviously those are big things, but also, relying on their pediatrician, I do a lot because they're often also navigating the mental health care providers in their area.
I get so many demands from teens and even their parents these days for Accutane for quite mild acne. I'm sure social media has a lot to do with this. How do you typically handle these requests?
Yeah, so I mean, most of my teens, when I ask them, they know a lot about isotretinoin. Where did they learn about isotretinoin? It's through TikTok. And that is really common. That's where they're gaining sort of, knowledge, and understanding the role of social media. Also, like, it influences the way we take care of someone. They have sometimes unrealistic expectations because they're constantly upward comparing themselves to what they're being fed. And so, why didn't that prescription work? And so their sense of normal expectations is altered. I mean, I think sometimes it just goes back to, what are your goals here? And giving them a sense of, disease severity, what are realistic sort of goals, and what they've really tried first, and, walking them through what you'd expect for a patient in terms of, here are normally the medicines that I consider before moving towards this. But again, if it's one or two subtle things, then it goes back to sort of, screening for something like, is there truly a dysmorphic disorder? Is probably worthwhile, but also setting goals, the goals of the parent, the goals of the child, which are sometimes different as well.
I also think it depends on who the person is. Like, there's a lot of kids who are and young adults who are more perfectionistic in their tendencies. Some of them may have body dysmorphic disorder, but some of them may just have like a different personality construct. And it's not uncommon for me. I have a patient population that is like the worried well, people with, public facing jobs, where if they have like 2-3 acne bumps, it's a crisis. So I'm putting people on low dose Accutane, but in the teenage population, I think if you're thinking about doing full dose Accutane and then they don't really have severe acne, then you should be thinking about what else is happening here. Because usually teenagers are not so keen on jumping into the process of going on Accutane, because so much of what we see on Accutane on social media is misinformation.
So finally, one last question. What resources can you tap into when you identify a patient being depressed?
I mean, first, as I already mentioned in mine, knowing the number 988, I think is super easy to put it on a patient care handout. You've therefore given them at least a tool that's in their hand if they're going to utilize as a 24/7, hotline. So I tell them, the number 911. And so this number is really important for teenagers these days to kind of have. So that's a quick thing. And then sort of navigating the landscape of mental health care, it really differs on your area. I mean, I do rely heavily on my relationships with their primary care provider as well to sometimes help navigate. Knowing the psychiatrist in your area, if you've practiced in an area for a long time, is probably helpful as well. Sharing patients, that's always really helpful. And sometimes having these conversations starts a conversation at home, and in and of itself can be important, because so many things kind of open up in a physician's room when you ask, questions about how you're feeling. How does this make you feel about yourself? And, sometimes their parents haven't had the opportunity to ask those questions. And so sometimes it starts a conversation at home when they're really thinking about, their quality of life, their sense of self, and motivates, the whole kind of family unit towards seeking care.
I'll say one other thing. In addition to 988, because this is a difficult question to answer, if you're looking for like really take-home points, the National Alliance on Mental Illness, NAMI, is a very good organization. They have a very easy to navigate website. And then if you're looking for referrals that patients can navigate on their own, Psychology Today is a very good website where you can search by people, I think by zip code and what insurance they take. But I would argue the harder answer and the better answer is that just like the primary care doctors in your area, and people don't think twice about canvassing the area to try to find referrals as dermatologists for primary care, I would argue that it's more critical for you to have mental health providers in your area that you feel comfortable with and you sort of understand their personalities, and you have them in your cell phones and you can reach out to them, because we will all have a crisis at some point in our practices, whether that's with an adolescent patient or an adult, and suicidality is going to be the thing that we worry about, or some sort of emergency situation. You want to know how to deal with it best to take care of the patient, and also medical legally for yourself. I hate to say it, but it's true.
But I mean, certain societies all have, National Alopecia Areata Foundation. There's a lot of good sort of quality of life things on that as well for, different disease states. Those can be useful resources. For LGBTQ kids, the Trevor Project is an incredible resource about kind of self-awareness, mental health, and resources as well.
Well, we could talk about this much longer, but that's all the time we have together this evening. We'd like to thank Dr. Reeder and Dr. Osa for a very insightful presentation, sensitizing our dermatological community to these crucial health issues for our patients' well-being. And we'd like to thank you all for joining us this evening. Good night.